on eliminating hepatitis C. Thank you for joining us for our November webinar on eliminating hepatitis C, the role for addiction medicine providers in Ontario. I'll start with our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The work of Medify and our partners takes place on traditional territories of the Indigenous nations who have lived on these lands since time immemorial. Medify is located in Toronto on the ancestral homelands of the Huron-Wendat, the Anishinaabeg, the Mississaugas of the Credit, the Haudenosaunee, and the Attawandarons. This is Dish with One Spoon Treaty Territory. Medify is committed to reconciliation. We recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. We respect and embrace the rich cultural and traditional practices of the ancestors. We invite our partners to reflect on the territories where they are situated and to join us in committing to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Before getting into the session, again, I'd like to remind everyone, please use the chat box and select everyone to make sure that everyone can see your messages. I'll be sort of collecting comments and we'll have time for question and answer at the end. And if you'd like to ask your question specifically to the group during the last 30 minutes, you can raise your hand and Lori can unmute you and give you the floor. Session evaluation will be circulated. Please complete that, and that's required if you'd like to get your credits. It is, I will save that. Well, I'll leave that up maybe just to entice you to think about our December session as we're working on our lineup for 2025. So it's my pleasure to introduce this evening's panelists. Kate Palbom is the lead of the Hepatitis C Elimination, Engagement, and Secretariat. She is an experienced policy and advocacy leader specializing in stakeholder engagement, communications, resource development, and knowledge sharing. Bernadette Lettner is the Ontario Hepatitis C Elimination Lead for Clinical Training, Guidance, and Monitoring. With over 17 years of experience as a community health nurse, she provides clinical training, supports healthcare providers, and evaluates treatment and prevention interventions. Bernadette has a keen interest in enhancing education, screening, and management of hepatitis C, particularly in equity-deserving communities. Her involvement in research has influenced evidence-based practices aimed at increasing access to hepatitis C testing and treatment, and developing innovative models of care that work in and for communities. Actively involved with community across the care cascade, Bernadette provides essential support to those affected by hepatitis C. Through her leadership and advocacy, she truly believes we can make significant progress toward hepatitis C elimination, while also improving healthcare system integration and access for all. There are a number of other presenters who will be introducing themselves and providing a bit of background and context when they join. And it's an honor to have with us Ken Lee, Emily Materik, George Cote, and Dustin Termarsh. So thank you. Looking forward to this presentation very much.
Thank you, Jennifer. Hi, everybody. I'm just going to bring my slides up and then get started. Give me one moment. And share. Okay. Right. Just clicking around, getting everything sorted out here. So, hi, everybody. Thank you for coming on a Wednesday evening. It is gray and dreary here in Toronto. I don't know what it's like where you are. But despite the weather, we're really excited to be here. We're really happy to have this space. Like Jennifer said, I'm Kate Palbom. I'm the lead Hep C engagement and secretariat in Ontario. I've got a background in communications, advocacy, and policy, and capacity building for community-based organizations. I'm newish to this role. I joined the Hep C core team in September of this year. And my role in the team is basically focused on driving engagement with Hep C elimination roadmap and supporting mobilization, network building, and implementation of its core recommendations and activities across the province. Before going into the deck, I just want to thank Medify for creating this space for us. We're really excited to talk with you about Hep C elimination. And I want to give a lot of appreciation to Lori and Jennifer, who supported us in developing our session and getting us ready to be with you tonight. My co-lead Bernadette and I have about 15 minutes here at the top just to give you some background and orientation about the Hep C elimination roadmap more broadly, and to highlight some opportunities for education, networking, practical strategies for adapting your work, and increasing HCV testing and treatment and cure. Here we've got a little brief outline of what we're going to cover before passing the mic to our fellow speakers. But we really envision this session itself just to reflect shared models of care more broadly and include some folks who represent the many roles and activities along key touch points within the Hep C care cascade. So tonight you'll hear from Ken Lee, Emily Materik, George Cote, and Dustin Demarche, who will discuss their experiences and perspectives from each of those points of view. And I just want to thank all of our speakers for coming together as well to participate with us. So what is the Hep C elimination roadmap? It's a guiding policy and practice strategy. It aims to reach Hep C elimination in Ontario by 2030. And you can see our specific targets on the left here. These targets are also aligned with the WHO targets for Hep C elimination. The roadmap outlines how Ontario can take action to increase the number of people tested for and diagnosed with hepatitis C, how we can expand treatment options for easier access, and advance policy and prevention strategies. If you go and look at that document, you'll see over 100 recommendations segmented over 3 parts, focused on system changes, priorities, and taking a population-specific approach. And those are listed here on the right side of the slide. We officially launched the completed roadmap strategy in 2023, and we're now working on implementing the recommendations across specific work streams. We're funded by the Ontario Ministry of Health, and we're very enthusiastic to be one of the first provinces with funded roles to support elimination work. So we know that elimination of Hep C in Ontario can only be realized through a population health and health equity approach. Within the roadmap, we've identified 5 priority populations listed here, and there are specific recommendations for each priority group. And this is a really big part of why we're here tonight, to connect with you all and talk about how to embed elimination in your work with people who use drugs, not just here today, but over the longer term through education, collaboration, and information exchange as we go along. So we've already learned a little bit about this, who's doing this work. So responsibility for implementing the roadmap sits with the 2 co-leads. That's Bernadette there on the left and me on the right. And we are housed at Vircan and Katie and have shared accountability to advance the roadmap. But we are sort of separate from those 2 organizations and leverage some of the resources available within them. What this means in practical terms is that we're working together to provide backbone support to an expanding network of clinical and system stakeholders and build relationships to support elimination. So an important distinction of this work is that it is very much implementation focused. The roadmap work in Hep C elimination in Ontario centers on leveraging, enhancing, and building pathways to Hep C testing, treatment, and care across systems to make sure that more people are tested and cured. In more formal terms, that looks like Katie and Vircan working together to pursue the roadmap's 7 key areas for action listed here. Our work aims to complement Hep C education and resources that presently exist in Ontario. And we'll come back to this later. But I'll note that at the end of this session, we're going to share some more details about an upcoming Hep C treatment education session delivered in partnership with Katie and Medify. And that's going to be happening in January and February of 2025. And I'll pass to Bernadette.
Thanks so much, Kate. Kate's still going to advance my slides, so I don't have to go through all the hassle of that. So when I think about doing this work, one of the most important things that I think about is how can we support you in your work? Because we know that asking just additional things of people, it's not going to get us anywhere, right? So what we're trying to do is figure out how we can embed hepatitis C treatment, testing and treatment within community in a way that ends up supporting you in the work that you're doing and not interfering with the work that you're doing, right? We know that within RAM clinics, there's a higher prevalence of Hep C than in other treatment settings. So we want to help folks to really embed HCV testing and referrals and maximize the impact of that. The aim is to support providers in finding ease with integrating Hep C care in their settings. So we want to know what's working and what isn't working so we can help to remove what we call the roadblocks to the roadmap for elimination. Kate, you can jump to the next slide for me. So let's talk a little bit about RAM clinics specifically. We've seen through the support of our work with Medify and also in data sets that are created through Medify and in looking at research in RAM clinics that there's a real commitment to addressing the need for Hep C care in RAM clinics and for people accessing RAM clinics. The survey that went out to Medify says well over 80% of clinics are testing and also treating people with hepatitis C. So we really want to figure out how we can end up maximizing those activities, ensuring that regular testing is happening and that access to treatment is something that's seamless for people as much as possible. Because there is only about a 25% testing rate in the data set. So we want to be able to improve that a little bit. There's a number of aspects of Hep C care that are already in place. We know that RAM clinics have developed relationships. They know their clients. They have frequent client contact with individuals that, again, people have higher prevalence of Hep C in RAM clinics, but there is wide variance in that, right? So there's some clinics where you might have low prevalence of Hep C and some clinics where 50% or 75% of people have or have been exposed to hepatitis C. RAM clinics are widely distributed across the province, and often they have close relationships with pharmacies, with frequent dispensing, and with standing medication orders. So they already work with pharmacies in being able to maximize treatment for individuals. So we really want to support testing for Hep C in RAM clinics as a standard of care. We want everybody who ends up connecting with a RAM clinic to be offered testing at least one time, and for people who are at ongoing risk to have regular testing every 6 months to a year. And we want to support treatment initiatives that are responsive to the individuals and to the community. Research into Hep C care cascades has shown that rapid treatment starts decrease the number of people who have Hep C but who don't progress to the next stage, which is accessing treatment. So we also want to talk about how, with accessing treatment, we can end up building integrated networks so that if somebody stops accessing services at a RAM clinic, it doesn't necessarily interrupt their Hep C care. So next slide, Kate. One of the things that we can talk about really easily is testing in RAM clinics. So we know that there's a lot of different ways that this happens. So some RAM clinics have on-site phlebotomy, right? So you have somebody who will draw blood, you have a way for labs to be picked up, and it happens all within the site. Sometimes RAM clinics will provide requisitions for individuals, and we know that that can be a little bit difficult, that a lot of times people don't end up going for blood work with just a requisition. But it is a little bit less cost intensive than having on-site phlebotomy available. We also know that there's point of care testing that's available. Up until this point, if individual RAM clinics wanted to order point of care testing for antibody testing, that was an out-of-pocket cost that's pretty significant, right? Being between $20 and $30 for a point of care antibody test. And when you have a high prevalence of antibody positivity within your population, there's not really a whole lot of value in doing an antibody test alone. So when you're doing antibody testing for people who have already received treatment, we know that that's not useful because once an antibody is positive, it will always be positive even following treatment. So it can't be used for reinfection either. It's only helpful for those first-time Hep C screen positive individuals. Another option that's available are dried blood spot cards. So this is, again, a finger stick test that ends up putting drops of blood on a card, and then it can be sent to public health labs Unfortunately, Public Health Labs doesn't provide those testing supplies. They don't provide the cards, but they will end up processing those samples. We know that dry blood spot cards are a little bit less sensitive than phlebotomy-based venipuncture, but still a good way to be able to allow people both to self-collect and also to have assisted collection within a space where a lab isn't available. So we know that people can also treat or refer on site after testing in RAM clinics. So in this, I'm not really wanting to tell you anything that you don't know, but just recognize that there are a lot of different options for how Hep C testing can be embedded within RAM clinics, and that really finding the right fit for your clinic and for your population is the thing that ends up leading to the greatest success. So go to the next slide here. Because what we would love to focus on now is some models that have been very successful in being able to integrate hepatitis C care into RAM clinics. So our first guest is going to be Ken Lee. He's going to talk a little bit about the experience that he's had in London and connecting with a nurse practitioner-led clinic. And then we'll have Emily Materik from CTC, the Comprehensive Treatment Clinic in Toronto, talk just a bit about how they initially started with a referral process, so referring individuals off-site for treatment, and then we're able to engage in a shared care model where testing and treatment happened on-site for individuals with the option to end up being referred to off-site group programming. So I do see that there was something that flipped up in the chat here. So let me just see. Does the organization have to pay out of pocket for point of care testing? So Franklin, right now, point of care antibody testing. So this is not the antibody testing that you end up sending to public health labs, but the test that you do that gives a test result in like 5 minutes. Those tests do have to be purchased out of pocket. We will talk a little bit about other ways that we can end up getting point of care antibody tests to RAM clinics who might be interested in that through partnerships with Ontario Hepatitis C hubs. So there are treatment hubs, but we'll get into that in a little bit if that's helpful. Yeah, no problem at all. So Ken, I'm going to turn it over to you, take myself off mic and hear all about the amazing program that you guys have been doing since the inception of the RAM clinic in London. Go ahead.
Sure. So the London RAM clinic has been in operation for about 10 years or so. But before the RAM clinic was in operation, we were actually treating hepatitis C back in the old days of interferon ribavirin. And we had a hepatitis C nurse that would do those treatments. And if you recall those treatments, they were difficult treatments. The clearance rate, the SVR rate was not that great. So for genotype 3s, we were treating for 24 weeks and genotype, the other genotypes for 48 weeks. And there's weekly injections and patients would come in. And then with the advance with the new direct antivirals, it simplified things so much. So we've been doing it for a long time. And then when the new medications came, we thought this is going to be the easiest thing in the world. And actually, it is pretty easy to treat hepatitis C now. You just have pan-genotypic medications that are taken either for 8 weeks, Mavorite for 8 weeks, or Epclusa for 12, and with very few side effects and very few interactions. And so the flow in the RAM clinic is with every new patient that comes into the RAM clinic, we will do an OLIS search to see what blood work's been done and on file. We don't repeat blood work that needs to be redone. So oftentimes we'll pick up Hep C diagnosis, even a viral load. We usually search back to January the 1st, 2020. So we get like 4 years or so of blood work. So a lot of times you'll have your your Hep C testing, your Hep B testing, your HIV syphilis testing, and that sort of thing on file, and some liver enzymes. A lot of people that you see will have known Hep C, which they may or may not have treated. And so the flow is that patients are offered blood work, and it's nice if you can, in a RAM clinic or any clinic, if you can do the venipuncture on site at the first visit. Some patients decline that and say, well, give me a requisition and I'll take it to the lab to get it done. Well, that means it's not going to be done because it is so much more inconvenient. And that's one way of putting off the blood work. So we like to do that. Once we screen the blood work, get the screening blood work done, you can get your hepatitis C results in about 2 days, 48 hours, and then at the follow-up in a week, and then you can review those results with a patient. We will do follow-up testing for genotyping and viral load if that's not been done before. If you want to treat a patient, you have to have a viral load done within 6 months of applying for the treatment. Um, the newest thing that's happening now, if you get a new hepatitis C result on a blood work with any Ontario lab, the sample gets what's called reflex testing. So they'll go ahead without an additional order to do the genotyping and viral load. So that's helped the flow quite a bit. Our intake blood work includes other testing, hepatitis B, HIV, syphilis. There's a lot of syphilis out there right now, so you can usually convince people to get their blood work done to check that, at least check that parameter. Once we identify a patient who is hepatitis C positive, if the patient is prepared for treatment and wants to get treated, we will go ahead and engage our nurse practitioner. We have a dedicated hepatitis C nurse practitioner. Cheryl Dale does that work for us. And we are fortunate in that Cheryl worked in hepatology at University Hospital for many, many years on transplants and hepatology. So she's a very well-trained great volume of knowledge in this area. Cheryl also has access to a fibroscanner, and so if we need a fibroscanner, we can get that as well. Within our RAM clinic, we do see patients who have other associated medical problems and they have no access, they have no primary care provider. So we do set aside a half a day a week to treat some untreated medical conditions, whether that's their diabetes, follow their HIV, treat their Hep C. And so we'll slot some people, a very select number that we feel they urgently need some kind of medical treatment outside of an ER, outside of a walk-in clinic, that we will do some of those treatments there and assessments, and that includes some of the hepatitis C work. And that's when the fibroscanner will be available as well during that half-a-day clinic. So the hepatitis C treatment doesn't necessarily impact the workflow in the RAM clinic in that way. We do a lot of the screening, a lot of the education as we see patients, but then the treatment itself, the more comprehensive assessment before treatment takes place at the primary care clinic that we've set aside. We run the primary care clinic in conjunction at the same time the RAM clinic is running. So patients can come into that primary care clinic, but also get their RAM clinic work done, whether it's a sublocade injection, renewal of anti-craving medications, or whatnot. So we don't create additional visits for the patient. We try to work into the hepatitis C treatment into the workflow of the RAM clinic. We were fortunate we were able to obtain some dried blood spot tests from Viracan. So that's the source of some of those supplies. We managed to get them gratis from Viracan. So thank you very much, Viracan, for doing that. Cheryl helped arrange that. Outside of the treatment of, the 8 weeks of treatment or 12 weeks of treatment, whichever one is selected, if the patients remain in the RAM clinic, we will do some of their annual follow-ups, their ongoing follow-ups you need to, after treatment, after you clear the virus with certain stages of cirrhosis and fibrosis, there still is the risk of hepatocellular carcinoma. So we will do some of that monitoring if the patients are still within our care. So the annual ultrasounds, the alpha-fetoproteins, we will follow if they're still within the RAM clinic. We do let the primary care physician know that this follow-up is required, but a lot of times the patients would prefer just to get it done with us, and we're happy to do that. It has not been a great increase in volume in the work at the RAM clinic, and it was fairly straightforward to integrate that into our workflow. And again, we found it easy to integrate into the workflow because we were used to the ribavirin interferon days, where patients were sick. They had to get injections every week, and it was a difficult endeavor. But now with the new medications, it's really, really quite simple with very few drug interactions and very few side effects, if any. Ongoing follow-up for other patients who do not have hepatitis C. We try to update the blood work once a year, especially for at-risk patients. Not always successful in getting that blood work done, but we try. So that's the summary of our hepatitis C treatment program. We did put together some stats on this and did manage to get a poster and a paper published on this back a few years ago, kind of pre-COVID, I believe, or early COVID days at ASDL in Boston, and I think in Montreal we presented something as well. Clearance rates were very, very good, approaching 95, 100%. So it's something that's doable. It saves consults out to other specialists. I believe it saves the system money overall. It is very cost effective doing it this way, and most importantly, we get hepatitis C treated, and the patients trust us to do that, and it's been a good thing to do. So that's a summary of our program. Happy to take any questions at this time.
Lovely. Thank you so much, Ken. I know that we have about half an hour reserved for questions at the end.
Okay.
So I'm gonna let Emily talk a little bit about what she has, but really appreciate that, Ken. And if people are interested in a follow-up, we can end up sending along that paper that was published on the work that you did in London. Great. So Emily, I'll ask you to come and let us know a little bit about your experience, both with referring out and those difficulties that Ken talked about, and then also with having on-site testing and treatment availability. Thanks so much.
Yeah, for sure. Thanks so much, Bernadette and Kate, for the opportunity. So my name is Emily Materik. I'm the clinic manager at Comprehensive Treatment Clinic, which is a multidisciplinary clinic in the East End of Toronto, although we deal primarily with clients who are living with substance use. And we initially started as a referral-based, coordinating with the Hep C team out of South Riverdale. So we would have our physicians refer patients to Bernadette and the team, and they would follow up very quickly, and it was working very well for us in that way. But it was a very hands-off way of doing things. At our clinic, we really pride ourselves on whole patient care, and we try to have as many services in-house as we possibly can. So I feel like we were, uniquely positioned to be a great pilot site for having the team come and do integrated on-site care with us. So that started off with meeting with Bernadette and Katie and the rest of the team, and they began coming on site to our clinic once a week for 3 months. And we did vary the time and of day that they came and the day that they came, just so we could, see as many clients as possible coming into the clinic. So what that looks like is that we had Bernadette and Katie in a room, in one of the exam rooms. And then we had some peer workers in the reception waiting room area, kindly with coffee and snacks, which is always appealing. And the peer workers would relate to the clients who were in our waiting room. And, we had a full range of clients there. So there were some who were aware that they had Hep C in the past. There were some who were concerned about Hep C and wanted to get tested and treated. There were some who were not concerned but chose to get treated anyway, and those that didn't want to engage in testing and treatment, but they were really happy to talk to the peer workers and just relate to people with other lived experiences. So it was really a beneficial relationship for everyone involved. Um, some of our staff are trained in phlebotomy. We do phlebotomy on site at the clinic. And so we did engage in additional training with the team to learn some, to do some more robust testing once the Hep C team had left our clinic. And the benefits of having the shared model, were immediate. We were able to reach quite a few clients that were able to access testing right away. Definitely having a small monetary reward for getting tested was very helpful for engagement. I think that our low to no barrier model really was amplified by having this additional service in place. And it was really beneficial. We continue to have a close relationship with the Hep C team, even though they've left us. And we're back to a more referral-based program. But with the additional training and education that our physicians and staff have. And I'm going to pass it back now to some of our wonderful clients who have lived experiences.
Amazing. Thank you so much, Emily. So we actually have both George and Dustin here. I'm going in the order that you see them on the screen, not in the order that they're going to talk. And they've both kindly agreed to talk a little bit about their experiences. So Dustin connected with our program through a referral process, and George connected with us when we were doing on-site testing. So I'm just going to pass it over to you first, Dustin, to tell us a little bit about your experience and what that was like for you.
Okay. So just to like preface it a little bit, part of my story, because I'm going to be talking about like how I ended up getting treated, how I went through the process or whatever. Like I have really bad anxiety. I have anxiety disorder, panic disorder, and PTSD. So I find it really hard for me to speak to people I don't know, or like even giving a presentation. So if I start speaking really quickly, I apologize. But also it's hard for me to take a step forward and go meet people that I've never really met before, talk to people. So with my path with the treatment or whatever, like at the time I felt like something was wrong with me. I didn't know I had Hep C originally. I honestly thought I had HIV at the beginning, but I knew something was a little wrong. So I decided to get tested for everything. So I did that like at my methadone clinic. Kind of lucky to have a clinic that has like a 360-degree type care model. So like they basically take care of everything that I need, which is really awesome. So like when I was getting treated, it told me I had Hep C, and in the beginning, like I was living on the street at the time. I was in and out of shelters. So I thought like I had the disease. I knew about it. I knew it was treatable, but I didn't really let it bother me or anything. But probably what made the biggest difference for me was at the time I didn't really know how I was connected with the Hep C team, but the clinic that did my blood work, they followed up with me. They told me to pick a place between South Riverdale, Queen Parkdale West, or Sherburne Health, but I was living out in Scarborough at the time, so I figured South Riverdale was closer. And I was lucky enough that they did all of the background work for me. So they ended up connecting me, sending my paperwork over to Bernadette, which was a lot of help. But what made the biggest difference for me was because I have a hard time reaching out to people. I probably wouldn't have even followed up with it. I probably wouldn't have even gone to South Riverdale on my own. But all of a sudden on my phone, I just get a text message from Bernadette, and it's like, "Hey, you've got hepatitis C. Let's do something about it." And that made the biggest difference for me, because I usually have the hard time like reaching out to people, speaking to people. So whenever it's the most distant, less personalized type of communication, either by email or by phone, or rather not by phone, by text, I prefer those methods in the beginning. And then once I get to know somebody, then I'm more like open to go and approach them. So it really made a difference, like reaching out to me by text message. I'd be able to talk to her, reach out. Like, I think I even message her sometimes at like midnight with questions, and she actually messaged back. Like, I don't expect anybody to go that far, but it was a huge help for me, actually. And like just making the initial connection. At the time I was in a shelter, like in Scarborough. It took about 2 hours to get down to South Riverdale. So I wasn't able to take part in they had a group, I believe, like every Wednesday or whatever, like a peer support group. I wasn't able to take part in it every week, but I guess they offered honorarium, so I tried to make it as much as possible. But just being able to connect with somebody outside of a clinic setting, like through like telecommunications, was a huge help for me. After like I spoke with her for a while, I was able to go in to South Riverdale, and then we did like this really long questionnaire about all aspects of your life, which is kind of like poking in all kinds of like different corners, which is really weird. But it was actually nice to connect with her and then find out that like the treatment is actually like really simple. Like I thought it was going to be like something really complicated, but all it is you take a medication for I was on an 8-week program, so all you do is take the 3 horse-sized tablets every day for like 8 weeks, and then it pretty much gets rid of the virus. It made it really easy because like I was going at the time, I was on the methadone program, I still am, but I was getting carries at the time. So she made it tie into my OAT like MMT schedule, which was really helpful. So every week when I go pick up my carries, I also pick up my medication for the HCV. And I really don't have anything to complain about. Like, it was a really easy process for me to follow, taking the medication. Just tying it into something that I was already doing, such as like my methadone and like my schedule of my carries, was really helpful. But I don't really have anything really to complain about. Like the one biggest setback for me, probably because at the time, though I was on OW at the time, I was also in the process of getting approved for my private insurance. So it's a like long-term disability. So when I'm on the private insurance, the insurance coverage only covers 90%. So like the biggest drawback would be like if I'm living on the street, how do I cover a $530 a week prescription? But at the time I was in OW and it was easy to work around, but like I could see that being a barrier for a lot of people, or like some people, I guess, say if they're not like on OW or ODSP, but no, like it was the easiest process for me was the communication, just communicating like informally over the phone, like text message or whatever. Because I guess like once I was transferred into her care, it was just really easy and simple. Too bad there's no more people like you.
There's more of me everywhere. Thanks so much. And I really appreciate the fact that you came in here to share your story for this, because I know it's not the easiest thing in the world, but you did great. Really appreciate it. Okay, so I think one of the really interesting things about connecting with Dustin, Dustin didn't know that he had Hep C until he was tested at the comprehensive treatment clinic, and then the referral went out, and actually we had your referral for a number of months. And I remember reaching out at one point in time and the phone wasn't in service anymore, because that happens. And then getting back in touch with Emily and the doctor who had referred you over to us and saying, like, is there any other way we can get in touch with this guy? Maybe when he's at the clinic, you can give him my cell phone anytime at all. But just that idea of being able to send a text message and say, like, hey, you don't know me.
Yeah.
You don't know me from anyone, but like, if you want to do something about this, we can do something about it. So like, again, thank you for taking the jump and you know, responding to that one.
Thank you.
Yeah. Okay, so I'm going to pull George in here now next. So George had a little bit of a different story, because we actually tracked you down at the clinic, you know, and you had a bit of a different way of engaging with us. So I really love this story. Go ahead, George. I'm going to let you tell the story about how we connected and how you connected with this guy over here first.
So for me, yeah, I guess I've done a lot of time in prison, and I don't necessarily, it takes me a lot to, I guess, connect with people. But once I am connected with people and I'm comfortable with them, I find things pretty easy to move forward. But like I say, I don't choose to connect with people very often. And yeah, it was one of the peer workers, Doug, that I wasn't quite sure where I knew him from, but I was sure that I know him. And eventually we figured out that it was from prison, well, jail, and he had a very effective way of coming across and, hey man, you want to get fucking $10 and get your finger pricked? And it was quite simple, and you know, and that's initially how I connected with Bernadette. And my girlfriend was with me at the time as well, and yeah, so both of us were easily convinced. I mean, it was a great idea, what I think of, you know, I think at the time I wasn't necessarily completely strapped or anything, but $10 is $10. And, you know, Doug was able to come across very down to earth, and there was another gentleman with him as well, John, yeah. And both of them, sometimes I'm not the easiest person to approach either, but you know, Doug and John had no problem just coming and sort of shooting the shit with me, and just let me know what they were doing there. And I thought it was really interesting that somebody that I had known from the past and was very open and honest about his story with me, Doug, and he was just very straightforward and honest, and you know, let me know of how he got connected. Now, I've always been a person, well, I guess I've been led to believe that I have an ability to connect with people when I choose to. And Doug chose to connect with me, and I connected with him, and it was an easy conversation, and it was an easy convince, you know. Like I said, I wasn't completely strapped, but you know, $10 is $10. And you know, I just really believe that, yeah, if I wasn't approached that way, I do get along with the staff at CTC, I believe it is. And I believe I was even told about the program by one of the doctors prior. And I believe it was fairly new when you guys first approached me. I don't think you guys were there for very long. But so I mean, the doctor part didn't really fly for me. So yeah, it was just it was very easy for me, for the simple fact that Doug was able to explain to me how he was in the position he was in. And he had shared he was homeless at the time, and he had met these people, and you know, things were going great for him in his life. And at that time, I think I was on the Sublocade. I think I had just started the Sublocade, and it took me a long time to make that step. And just the way it was put out to me was, you know, something. And I knew that I had Hep C for a number of years. I had Hep C since I've been 18. I think I was 45 or 46 at the time. And I just truly believe that, you know, it didn't affect me or bother me because I didn't allow it to. And I believe that, and I sort of still do. But just everything from being connected with the program, a lot of avenues, a lot of doors opened up for me. And it was, yeah, I really think it was the peer workers, Bernadette, of course, but I don't think I would have really gave Bernadette the time of day if it wasn't for Doug explaining to me that how cool of a person she was, and fuck, they were just there to help. And you know, he really, it really hit home when he explained that to me. And yeah, a lot of growth and a lot of good things happened for me connecting with the program. I think I was ready for something new and just healthy. It took quite a bit of convincing to get my partner to come along and do some of the Wednesday groups and stuff. But yeah, it was just it was a beautiful thing, and I'm very, very happy and pleased that I did choose to do it. And since then, I've still had my ups and downs, but it's an experience I will definitely never forget. And I am very pleased that I made it through the program, that I cured myself from Hep C, my girlfriend as well. And I also did the peer training, which was a great thing. And yeah, it was something that I believe that I would have no problem sharing, and I have shared with numerous people. I haven't had the success that Doug has had, but with convincing other people to, well, I guess I kind of have brought a couple people around, but yeah, no, it was definitely the peer workers that were able to connect with me and people I just were easily connected with. I don't know what people know about Doug, but he used to have a pretty significant name years ago. And yeah, so from somebody like Doug being able to just be straight up and share the truth, it was pretty significant. So I thank Doug for that, and I thank Bernadette, and I think the program is great, and John as well. And yeah, it's been great, and it's helped with a lot of other medical issues that I was, well, I guess just my age and stuff, and you know, I've always believed in my mind that if you don't let it bother you or think about it or dwell on it, it really can't affect you. And I still believe that, but I'm still very pleased with everything that's come out of the program, and I'm very grateful for it. So.
Thank you, George. I think one of the things that really strikes me about, like, when you tell your story is this fact that you knew you had Hep C and you'd known for years and years and years, and people had said, hey, you should get this treated. And you were like, it doesn't really bother me. There's not really any reason for me to go and seek that out. But it took somebody who had been there, who'd been in that place, who'd had Hep C to be like, you know, you can do this, come and connect and you can get it done. And then what was really nice is that we weren't able to just treat you. We could also treat your girlfriend, right?
Yeah.
And so that like decreased the risk of you being re-exposed to hepatitis C within that relationship and within that part of your world. So having that flexibility to connect with you, to connect with your girlfriend, to offer you both treatment kind of at the same time, right? And then allow you to pick and choose what aspects of engaging with the program you wanted, right? So if you wanted to come to groups, which you did all the time, I believe your dog also graduated because your dog came religiously to all of the groups as well. And just being able to see your growth over this time, to see you go from a place where things were really rough, to having your own place, to having a job, to having like a different sense of yourself in the world right now. I think it's been fantastic for us to be part of that journey as well. Thank you, George. Yeah.
Thank you very much.
Yeah. So I think we can turn it over to, and we're just, there's appreciations in the comment section for both Dustin and George for sharing your stories. But I can turn it back over to you, Kate. I think that you had a couple of resources that you wanted to share, and then we'd love to be able to open this up for a little bit more of a conversation, to be able to hear from folks either questions you have about how to engage in HCV treatment or testing, and also what you think needs to happen in order for this in order for Hep C elimination to become a reality, in order for it to be something that you can engage in easily within your spaces and practices. So let me turn it back over to you there, Kate, and we'll just stay on camera here for the next little while.
Thanks, Bernadette. Folks, I'm just going to share my screen one more time. So this is a follow-up item, couple of follow-up items. So as a complement to this session, there's going to be a Hep C treatment education session delivered by Katie, and that's coming up in January and February. So this is going to include 3 self-directed modules, and there'll be also an online real-time session with the Katie educator. I'm going to share the registration, which is open now, in the chat for you all. The course will be facilitated, like I said, by a health education coordinator, and there'll be a combination of online interactive e-learning units, discussion board assignments, all before the online meeting happens. And folks will get a certificate on completion. This is a course for service providers working with clients who have Hep C or are at risk of Hep C. It doesn't provide in-depth clinical information, but if that's something that you're looking for or you want more information about that, You can reach out to Bernadette or I for more information about resources and places to expand your clinical knowledge, or just get in touch with us generally so that we can connect, learn more about your work and your needs. And you can also visit our website, nhipc.ca, to read the roadmap and to learn a little bit more about us. And I think I'll pause and leave it there. Do you have anything else you want to add, Bernadette?
Yeah, the only other thing that I wanted to let folks know is that we are in the midst of developing a clinical content. So for prescribers to be able to confidently start Hep C treatment within your practice. So it is a 30-minute module asynchronous learning. So you can end up doing it at any point in time that you have a moment. And it's going to be accredited for CME credits next in the January term. So they're closed for accreditation right now, but it'll be in the first cycle in January. So at that point in time, anybody who wants to do an accredited course can go through that. The only other one that I wanted to mention is that the Echo Liver does still exist. And so for people who are interested in learning a bit more about liver disease in general, and then specifically around hepatitis C, there is an Echo Liver program that is also CME accredited, and those run as a didactic and a case management session on Mondays. And so we'll make sure that you have that information as well.
Yeah, that's great. And we'll share our deck and a few additional resources, perhaps along with that paper from Ken, in the follow-up to this. And folks in the Medify Google group will also get a nudge from Katie about the course that's listed here. And that's all I'll say. I think we're going to move on to discussion now. And I believe, is Jennifer going to moderate discussion or open for discussion?
I'm here.
Hello.
I see a comment from Mike. Please put the link to the modules in the chat. Yes. I'm going to take the opportunity, since you mentioned CME, to correct myself. And I asked people to fill out the evaluations in order to receive credits. That's not true. I don't know where that came from in my mind. We really like evaluations because they help us in planning and we share them. So I just want to correct that. So please feel free to keep adding questions to the chat and I can pose them, or if you put your hand up, Lori can invite you to ask your question yourself. I have many, so I'm happy to get started and I hope that there will be more discussion. My first question, first of all, my first comment, thank you so much for sharing your personal experiences. It's so meaningful for us to hear about the challenges, the benefits, and what you feel really sort of got you looped into making the decision to do treatment. And it sounds like it's really had lots of spillover benefits in terms of your feelings about your general health and where you are in your lives. And so I really want to thank you for that. One question is, we've been talking about hepatitis C for a long time, and there's been education kind of targeting addiction-related clinics, specifically methadone OAT delivery, for a long time. Why do you think that we are still struggling to create? I mean, I'm very grateful to know that there's a roadmap and we've got a different vision, but why have we been struggling, and what is going to make the difference, do we think, in terms of getting to that next step in terms of testing? And then from testing to treatment. I know that's what we're talking about, and it's great to hear these examples, but I'm wondering sort of what is the bigger picture? What do you feel as people involved in this that's going to make that difference?
Jails.
So George,
anyone in the panel would like to address that?
Yeah, so George has actually got an idea of it right now.
Great.
And go ahead, George.
I said opening it up in jails.
So George is saying, like, in jails, in prisons,
Mhm.
being able to offer hepatitis C treatment, but also
just if peer support workers were able to explain to inmates their experiences and their benefits and what is just out there, I think that would be a huge thing. I think as well, you know, trying to put some sort of incentives, some sort of housing or some sort of, I mean, I know I'm thinking of a much bigger thing, but there's a lot of people, like, you can see what's going on with the housing aspect for a lot of people, and I think if there was some sort of, not halfway house, but something, if people were even to start the treatment in jail or be tested, and there's so many people that have things set up and have so many plans when they're in jail, and the system sort of tries to help. I've done 17 years in the system, and you know, thankfully I've been able to keep myself out for quite some time now and out of trouble, but here nor there.
Can I tell you a good news story about that, George? So this year, for people who might not know, for the first time ever, provincial prisons are starting people on hepatitis C treatment. This is huge. So people are doing testing and treatment in prisons now for the first time ever, consistently across the province. One of the things that's important about that is it's called opt-in testing. So people have to step forward and say, I want to be tested. But I absolutely agree with you that having people and people with lived experience in prisons doing education and encouraging people to get testing and treatment is a really important thing. There's actually a group in Australia who ended up doing peer-led, prisoner-led testing for their population.
Okay,
And they
so-
ended up going from 10% of prisoners being tested for Hep C to over 90%. And they've kept that for over 5 years, 90% of people getting tested. So I think you're onto something there. But I think the other thing that you're talking about is the fact that, like, when we talk about hepatitis C, when we talk about folks who are accessing RAM clinics, we're talking about people who have a lot of other things that are going on in their lives and multiple different things that need to be worked on. And I think this speaks to what you're talking about, Jennifer, that we know about this, but it's just another thing on top of the many needs that people have. And sometimes it can be overwhelming to think, well, just one more thing. And even if something's a little thing, doing one more thing can feel like it's a lot, right? And I know that, like, being in the world right now where there's a toxic drug supply, where there's a housing crisis, an affordability crisis, where all of these things are intersecting, doing that one more thing of hepatitis C can sometimes be something that doesn't actually end up being the top of the list. But I think one of the things that's really interesting about the conversation that we've been able to generate here today is that hepatitis C treatment in and of itself is one thing, but it's connected to a lot of other things, right? And so your ability to be able to engage in a healthcare system and develop trust in a healthcare system is a bit of a novel thing for you, right? That wasn't something that you were able to engage in before hepatitis C was the door that kind of opened into that space, right?
For me.
Yeah. So I think that it's one of those things that can have, as you mentioned, Jennifer, far-reaching effects on individuals. I think it's also one of those things that it's so successful, right? And we love to build on success, and being able to say, like, hey, I did this. I cured my hepatitis C. This thing that made me feel sick all this time, Dustin, I didn't know what was wrong with me, but something was going on. Like, being able to be like, I got rid of that. I did that. Yeah. That's a success that can also be built on. And it's such a good news story right now. And sometimes we need that little bit of sunshine when it's dark, right? And that can be one of those hooks that helps us to connect in community. And we do have Doug over here sitting in the corner.
Doug over there in the corner.
And I think, like, Doug's another one of those people who can tell you that it seemed like such a small thing, this tiny little virus.
Yeah, and it's connecting with people that can relate, and yeah.
And it made such a difference in your life too, right?
Huge.
Yeah.
I actually run the program now.
Yep.
That's awesome. Just kind of staying with corrections for a minute. There are a couple of questions from Mike Franklin, who's based in Sudbury, does a lot of work in corrections. Wondering if there are any examples of well-organized Hep C programs in corrections. And I think a really interesting question, what would be the role of incentives to seek treatment in corrections? Some might see incentives as coercive.
Absolutely, Mike. And that's why incentives are not used in prison situations whatsoever. And it's also one of the reasons why when corrections are looking at referring to people to Hep C treatment, they have been very cautious about engaging in pharmaceutical programs or in other ways, because they want to make sure that it's not coercive, because we understand that when people are incarcerated, that their ability to consent, to opt in, to opt out of a lot of things is suspended, right? So for sure, when we talk about well-organized Hep C prisons in corrections in Ontario, we're brand new, right? So I would say that we're still pretty young in that. PASAN is the organization that does. Sorry, Doug wants to speak to this, so I'm going to turn it over to the expert.
And say what the name of that organization is again, please.
PASAN, it's called. They do newsletters. They go into provincial and federal jails, and they support inmates. So PASAN, now I lost track of what I was just going to say, sorry. The jails, if they had people with the lived experience, that would all, the incentive would be needed, because we can relate to one another much easier than somebody that don't have that experience of going through Hep C treatment. And there's still so many myths on Hep C treatment. A lot of folks still think it's interferon. So I think it's valuable to have people with lived experience to do these outreaches in the jails and prisons.
And just to explain that, the first time I ever experienced any kind of Hep C treatment, I was in a cell next to a person that did the interferon. And man, did that guy go through hell. So that was obviously my outlook on Hep C treatment, that it was this fucking thing that would, make you sick as we could possibly be. I think as well, I know a little bit about different things, but, I think like an incentive is, if somebody was engaging or starting the Hep C program in jail, if they were perhaps guaranteed not housing, but a safe bed at the very fucking least. It's a very slippery slope, those first week, 2 weeks out of prison or out of jail. And a lot of people don't have family or resources, and they go back to what they know. So if, people were offered something like a safe bed, and somebody was able to explain to them what a safe bed was, not you'll get out and get to go to a shelter. A safe bed is much different than a shelter. So for the government to spring for a 30-day fucking bed for somebody, I think it would save the government a shitload of money in the end, because that person has at least got a fighting fucking chance.
Yeah. So it's basically supporting prisoners up on their release, which they're supposed to do anyway, but they don't. So.
And we do know that if you're in prison and you're looking for a shelter bed, you cannot call and request a shelter bed until you are released, right? So I think that these ideas of how these systems could integrate better in order to support people, 100%. There's a really interesting document that we can also end up circulating around that was created by INSU, which is the International Network of Hepatitis and Substance Use. So a group of individuals who actually based out of Switzerland, but the main educational office is in Australia, and they've just created a toolkit for how to effectively provide hepatitis C treatment in prisons, and these considerations that George is talking about, ensuring that people can continue treatment uninterrupted on release. So we can send those around too.
That'd be great. Yeah, we know that that first 2 to 4 weeks is such a risky time. I mean, it's hard enough to continue methadone or Suboxone. So again, a great argument for, linking all of these things together. And from an investment perspective, I agree with you completely, right? Those would be dollars really well spent. So a majority of us are working in community settings, RAM, but not only RAMs, lots of other sort of methadone or addiction care settings. Can you give us some advice about what's coming up in terms of partnership opportunities or funding opportunities? The idea of doing blood spot testing is great, but clinics are not likely to come up with the dollars to purchase those kits on their own. So what could we look forward to or leverage?
Yeah, for sure. So I think one of the things that we definitely want to be able to engage in more thoughtfully are the Ministry of Health funded Ontario Hepatitis C teams. So there are 27 teams, I think, across the province right now. And I actually did like a fun little mapping exercise where we took a look at RAM clinics and we took a look at hepatitis C clinics. And for the vast majority of the province, RAM clinics are located within a reasonable distance from hepatitis C treatment clinics or within the catchment areas of the Ontario hepatitis C treatment teams. So the Ministry of Health announced for the first time this year that they would end up funding point of care and dry blood spot testing for the Ontario hepatitis C teams. So this is one of those things where I think that it might be of greater benefit for RAM clinics and Ontario hepatitis C clinics to develop formalized relationships that end up doing the same kind of thing that the Toronto Community Hep C Clinic did with CTC, right? So looking at having on-site testing with people with lived experience, because Ontario Hep C teams are multidisciplinary teams that include clinicians as well as people with lived experience, to offer increased testing opportunities for clinics, but then also to look at creating kind of a hub and spoke model. So if your clinic can do testing and testing alone, that's fine. There's a place where people who are found to have hepatitis C can be referred. If your clinic needs support with doing testing and reaching, but you have the contacts with the individuals, then that's fine. That's a place where, if you have the space on site to be able to host an organization to come in and do that testing, that we can end up looking at how to make those connections and develop those partnerships for sure. I think, so as Ken mentioned, VIRCAN is the organization. So VIRCAN is the Viral Hepatitis Care Network, and they had received some research funding to be able to offer point of care tests. And so that's how they were offering point of care hepatitis C antibody testing and dry blood spot testing. So VIRCAN is actually the organization that will be providing testing for the Ministry of Health funded Ontario hepatitis C teams going forward in the future. So these organizations are interlinked in their ability to provide testing support for individual organizations, and going through the Ontario hepatitis C teams as kind of a hub within a community to be able to be more like a distribution center is likely the way that things are going to be able to move in the future. So that's hopeful.
So it is hopeful, but I'm curious, this is a question maybe partly for Emily, but for everyone. It sounds like, while there was support and there was a pilot, CTC was, able to offer testing and treatment all in one place. But that partnership is not, if I understand correctly, happening. You're back to referral mode. So I'm curious about, maybe I misunderstood, but what if I'm understanding correctly, what would prevent you from continuing to treat on site and prompt, that sort of shift back to the previous model of care? What can we learn from that?
Jennifer, if we could have the team on site, once a week all the time, that would be amazing. We would definitely have them on site. I think the reason why we don't is twofold. Number one, they're not available to be on site with us right now. And also that we were able to reach a lot of our clients. And although we have new clients all the time, and that's so it's not to say that that wouldn't be very helpful for them to return. They're very welcome to return. Um, but we were able to reach quite a lot of our regular clients at that time throughout that 3-month period. So it was, really beneficial for us. We'd love to have them back. I have to say again, the peer workers, especially having those people with lived experiences. Doug, shout out to Doug, on
Thank you.
site,
Thank you.
was so wonderful and really made everyone feel a lot more comfortable. It's one thing to have your doctor recommend something. Bernadette is very personal and wonderful, as is Katie, but to have someone there who can say that they've been in the same place really makes a huge difference. So if any of the clinics have space and time to be able to work and have a team on site, especially with with peer support workers, I highly recommend it. I think that you'll get the most engagement that way. But yes, so that's the reason why we would have them back if we could.
So I'll say two things to that as well. Jennifer, part of the reason is I left. I know. So capacity for the treatment team ended up going down as I was pulled into this more provincial role. I'll say that the other thing is when we end up offering testing for the first time at a site and we end up offering testing to everybody at that site, then we can do a one-time screening for everyone, right? If we and over that 3-month period, we were able to cover the majority of folks in the clinic who ended up coming in to do testing for them. Now, if we come on a monthly basis, then we might end up only hitting a couple of new folks a month, right? So we don't have the same volume of individuals that we can test. So really the idea going into it was to be able to kind of get through the backlog of people who were there, but then also to support the clinic in being able to engage in this process outside of us necessarily being there, and to show, hepatitis C treatment is easy. Different clinicians ended up kind of like taking on additional training to become more comfortable with the idea of doing hepatitis C treatment in-house. The pharmacists now know what the medication looks like and what's to be expected. So just kind of going through as like a gentle introduction to it. And Emily, as well as other individuals at the clinic, did end up learning how to do point of care testing so that they would be able to offer that to clients on an ongoing basis. I think like as we've talked about, it gets to be a little bit of a difficult thing, like adding one additional test in. There is a time constraint. There is that concern with it. Having staff come on site who are paid by an external organization to do the work in your clinic, obviously there's a benefit to that. And so I think that when we're looking at sustainability, the idea of bringing an organization on site makes good sense when we've got a high volume of people that we're testing and being able to reach out to. But having a group on site for 4 hours and maybe testing 1 or 2 people is probably less valuable, and it would be more useful to have a broader network of people who are engaged in doing testing as opposed to one organization going around and doing the majority of testing.
So that makes me think about something else that came up a little bit in terms of how often to test. I think maybe Ken mentioned, there's kind of a whole panel of blood work that we do when people often first come to care, and then think about trying to repeat it once a year. So I'm curious, both for the clinicians on the team and then for our presenters with lived experience, in thoughts about what is the best way to act as a reminder to test effectively, right? So for example, as per this idea of you test everybody in 3 months, you kind of get through the backlog. Is it to say, January, we test everybody, Is it to have a marker in the person's chart so that it's, once every 12 months on a calendar, but that's always rotating? I think we all have these ideas and we're missing opportunities, obviously. And curious about what you think around timing, system prompts, and then, the team here has really mentioned incentives, what the role there might be as well. So that's probably for everybody who's on this panel to share their thoughts.
I'm always the one who goes first because I have so much to say, but Doug's got something.
So you're saying for the testing, I think that would be actually asking each individually, personally, if they need the testing, maybe they're not at risk anymore, or asking them, have you been at risk? It's being straightforward and honest.
I think that also a lot of it has to do with what clinic capacity looks like, right? So let's say you have a phlebotomist that's on site once a week, right? Then does it make sense to do rolling testing? And every time the phlebotomist is on site, they have a group of people that they're doing testing for. If you don't have a phlebotomist on site, does it make sense to do annual testing every January and just have the entire group that's connected to it? And I think that there isn't a wrong answer with that, right? I think that we do need to do more testing and screening. That's absolutely true. But how we individually go about doing it can look like a lot of different things. So sometimes, like, we've done a barbecue and people all come together and they end up doing testing, or we leverage World Hepatitis Day and say, like, hey, here's an event and we're going to end up offering testing during that time, right? So I think that there's ways that it can be embedded episodically, and get as many people tested as possible, as well as being able to do it like first intake and then let somebody know if you ever have a risk event, let us know and we'd be happy to test you. And just like destigmatizing what testing looks like. I think when we normalize testing, we destigmatize testing as well. Go ahead, you got something to say, Justin.
Yeah. Also, like she was talking about like a risk event coming up. A lot of the times when I'm going to like my methadone clinic, I'm speaking with the doctors. Like they usually ask, like, how are you using? And if you're talking about like IV use or whatever, are you sharing with somebody? Like if people are open to sharing that information, and like if somebody like flags something that could be a risk, like, yeah, maybe I shared like supplies with somebody, then it could like help you target which ones to test. So then you're not like going out like doing the whole population, like because it's kind of hard to go to a clinic and be like, okay, we're going to test everybody, like there could be like over 3,000 people at my clinic, so like you need to kind of like lower it down into target groups. So like knowing what people do and like if they have riskier behavior can like help as well.
Yeah. And so we're getting into the philosophy of risk-based testing versus universal screening, right? And I'm going to say, like Dustin, I'm on camp universal screening. I think everybody should get a one-time test in their lifetime, and that people who are at ongoing risk should be able to continue to access testing. And I think, like, again, that idea of, I don't necessarily trust somebody that I don't know yet, right? So am I gonna tell the doctor that's prescribing me something that might be impacted by my disclosure, whether or not I've had a risk event? Maybe, maybe not. But if, like everybody else in the clinic, I end up getting tested once a year, it takes the risk associated with disclosure away and normalizes the testing as a way to access additional services and care, as opposed to a punitive thing, which I think sometimes people can be concerned about, right? I'm getting nods over here. People can be concerned about it, whether or not it actually happens in reality. It is a concern, right? Yeah.
It's Ken here in London at the RAM Clinic. But we do all kinds of different strategies. Kind of in general, we will try to test people once a year. However, not everybody wants to get tested every once in a year, so we don't achieve that goal for sure, right? We'll have posters in the rooms that say, "Have you been tested for hepatitis C recently?" All the staff have been trained in the treatment of hepatitis C, and so they know what the general guidelines are, and whoever sees the patient that day knows about hepatitis C, knows the treatment for hepatitis C, knows about testing. If there are people we particularly want to get tested, we will put a reminder up on the chart. A little sticky note pops up. As soon as that patient's chart is opened, there will be a little yellow sticky note, electronic sticky note to kind of trigger the question. So it's a multifaceted approach. There's not one way of doing it, achieving this. And, certainly we don't get 100% of people tested, but we certainly offer it to 100% of people. And what's the uptake? I think our uptake in testing is probably about 80%. So I think that's pretty good in our RAM clinic.
I'd agree with you, Ken. I think like the average is around 27% of people accessing a RAM clinic were tested, and that was through a data set that, again, this is 2019, so it could be a bit dated now, and we know that things end up changing much more rapidly than our access to updated data. So apologies if I'm talking way back in the past now and things are really different now, but 80%, like that's a great target to be able to reach.
Yeah, it's I think that's where we're going to peak out is about 80%. You can't get everybody tested because not everybody will agree to get tested. But we have a specific coordinated approach to try to approach this problem because we've been treating Hep C for a long time, and the current treatments for Hep C are so easy that it's a shame not to treat hepatitis C now.
Agreed completely. Any last words or messages from anyone on this this panel? Any last questions from the group?
Let's try our best at eliminating Hep C.
Doug's giving a rallying call.
Sure.
I'd also I'm very open to people's ideas or suggestions or being able to tell us what things would you like us to move forward in, either like an individual level, in a policy level, in a systems level, to end up making things easier, to make this something that would be more engageable for folks. So please feel very free to reach out with absolutely any thoughts, suggestions, absolute gripes, or I'm good at a rant from time to time. Happy to hear them from others as well.
Well, the things that really stood out to me from the presentations around, what makes that difference is both relationships and convenience. So making it easy, but having people that you trust, and certainly it seems that having peers to help educate, help destigmatize, help walk that walk sound like they're really impactful, and some great suggestions about treating within the correction setting, and thinking both sort of big picture and then kind of locally about what's working within your own setting. So thank you. That's a lot for all of us.
Really appreciate this time that you've been able to carve out for us to speak with you tonight.
Looking forward to those modules coming up in the winter, more learning opportunities, and none of us should. That 27% is not a good number. Thank you. Thank you for joining us. Would everyone please fill out evaluation forms, not for credits, but just so they're filled out. Please join us in December. Our session is a week early to move things a little bit away from Christmas and the holidays. We'll be talking about smart recovery and craft, working with families. And we've got a lineup coming up for January. And if anyone has been thinking about submitting an abstract for a presentation for the Medify conference in April, the deadline has been extended to Monday at 9 a.m. So we're still welcoming abstract presentations for snapshots, for talks, and for workshops, particularly looking at, sort of diversity of settings and populations. I see Bernadette, Doug, you've got something kind of brewing in your minds there.
I just got a thought.
I said I would love to take a look at it. Yes.
Okay, that's great. I think you have that info, Bernadette. If not, we can.
Yes, I do.
Okay. Have a great night, everybody. Thank you, everybody. In case I miss anyone, Doug, George, Dustin, Bernadette, Kate.
Thank you for inviting us.
Ken, it was really great to have you, and your participation added a lot. Thank you to